This type of fracture is unusual and difficult to diagnose with standard X-ray. The surgical approach is not really easy and can evaluate in arthrosis. If we suspect it, we make a CT scan, and you can see the fracture. So, the aim of the study was a new approach of the lateral osteochondral fragment of the talus, respecting the soft tissues, in particular tibiofibular ligament and interosseous ligament. We had two possibilities: the osteotomy of the fibula described by Prune and al., and using the fracture of the lateral malleus transfocal approach. Our osteotomy is made in two cuts. The first one in front of the joint of the talar and the tibia, and the second one make a bone triangle with insertion of anterior tibiofibular ligament. Here we have a good approach of the lateral facet of the talus. We can cut the anterior talofibular ligament, and only if necessary, we cut the posterior tibiofibular ligament, like here. The reconstruction is very classical, with 1 or 2 lag screws and 1/3 tubulate plate. This is post-operative X-ray. The study is retrospective, continuous, and monocentric. We had 5 osteochondral fractures on the lateral side of the talus between October 1994 and January 2006. 4 patients, 3 male and 1 female, where fracture was bilateral, average age 20 years, and every patient had high energy injury, car crash, or fall from high place. This is preoperative CT scan. All patients had one, and every patient had preoperative X-ray. In 3 cases, we make osteotomy of the fibula, and in 2 cases, we can approach through the fracture. All patients was operated in emergency. Reduction and fixation of the talar fracture was made with adsorbable pins or fibrin glue. If we had subchondral bone impaction, we can reduce it and graft with iliac bone or resorbable TCP. We made below-the-knee cast for 6 weeks and systematic consultation at 6 weeks for 3 and 6 months. As a result, the maximum follow-up is 7 to 8 and 40 months, and the results are quite good, with 1 very good, 2 good, and 1 medium subjective result. At the clinical exam, ankle motion was quite good too, with 15 degrees of dorsiflexion and 40 degrees of plantar flexion, with normal subtalar motion. Each patient was able to go back to work. At standard X-ray, we had good union of osteotomy at 3 months. In 4 cases, regular aspect of the articular surface between the tibia and the dome of the talus, and 1 was irregular, but it was in an intrafocal approach. No complication like non-union of the osteotomy, no syndesmosis instability, no septic complication, and no turboembolic complication. This is an example for the patient who had bilateral fracture. The right and the left side. This is the X-ray at 18 months. The osteotomy union was obtained at 3 months, and here we can see the joint ankle is quite good, and no syndesmosis problem. The result seems good, but it's only a few cases. We have a good vision of the talar lateral facet, and the approach respects the soft tissues. It seems invasive, but we have no clinical consequences. And this metaphyseal osteotomy makes less non-union than diaphyseal osteotomy described by Menz or Mascolet, for example. A little question is the price of arthroscopy in this kind of fracture. It seems quite little, but when we approach it surgically, it's a bigger fragment. And this transmalleolar approach could be a possible approach for mosaicplasty, maybe. Thank you for your attention.
There are time for a few questions. So my question is, what is the rationale for this osteotomy? Is there any advantage over the conventional
Yes,
osteotomy?
because we want save the soft tissues, and each ligament is respected. We have a good union of osteotomy and no syndesmosis trouble. So bone consolidation seems maybe better than soft tissues consolidation.
Do you have any study to provide that you have a better exposure? What about the exposure?
I don't know. I don't think so. I don't know.
Okay.
But in this kind of fracture, we have just a few patients because it's a little bit rare, and so it's difficult to try in real patient.
Okay. Any more questions? Okay. Thanks for your nice presentation.